Sir, good evening, sir. Hello.
Yes, good evening, sir.
Am I audible, sir?
Yes, sir. Yes, sir. You are audible, sir.
Can we start, sir?
Yes, sir. Yes, sir.
Very good evening to one and all. Today we have a speaker, Dr. Aarti. She is an assistant professor from Department of Emergency Medicine, SRM Medical College, Chennai. Over the next 45 minutes, she is going to talk about the myths in acute ischemic stroke management, what we encounter daily and day out in our emergency room. So this will be a eye opener. So a lot of time, even the general physician, general practitioners used to call us and say what to do and how to do and how we will do this. So all the myths will be busted here. And if you have any questions, you please post in the chat. We will answer at the end. Thank you. Dr. Aarti,
Yes, sir.
please take over.
Yes, sir. Yes, sir. Yes, sir. So, good evening, one and all. I'm going to talk about acute ischemic stroke and going to solve the myths in stroke management. So, every day in and out, we see a patient who is presenting to us with stroke. Okay, so we know how to manage them, but we have so many doubts in us when we are dealing on with a ischemic stroke patient. So I will be here to clarify few doubts about the management of ischemic stroke. Okay, so any neurologist you see, they will tell time is brain, because we lose about 1.9 million neurons every minute of delay in treatment of stroke. Okay, so that's why every hospital has a ischemic code blue stroke codes, which are very effectively functioning in many of the hospitals. So they have the stroke codes being running efficiently in most of the hospitals. Time is brain. Okay, so we delay every seconds, every minute, we lose about 1.9 million neurons. That's why time is brain. Okay, so our aim in stroke management would be, okay, to reverse the brain ischemia before it causes permanent brain damage by recanalization, especially thrombolysis. Okay, then to prevent further stroke and evaluation and recurrence by giving an antithrombotic agents. And then we optimize a patient's medical condition and prevent the common medical sequelae which comes after the stroke, which we are maintaining the homeostasis of the brain. And then we maintain a functional recovery, which means we are doing a early rehabilitation, not only prescribing them with an antiplatelets is the treatment of stroke. Okay, so also maintaining the blood pressure, the sugar levels, to maintain the proper body temperature, and giving them early rehabilitation is also very important in terms of stroke management, because they go for a strictures and they have stiffness in their body. So if you don't start early rehabilitation, they will go for a permanent stiffness that cannot be recovered at all. Okay, not only giving an antiplatelets as a treatment, but also treating the other parts like controlling your BP, diabetic, your fever, and starting early rehabilitation is also a treatment and a part of stroke management. Okay, so what is a definition? So physicians, everybody are very fond about definitions, pathophysiology, everything. So the definition is sudden onset of neurological deficit due to disruption of blood supply. Okay, so we also know, when we are dealing with stroke, we should also know about another term called as your transient ischemic attack. Okay, so in which the neurological deficit is resolved within 24 hours. Okay, so by classification, we know stroke is divided into ischemic stroke and your hemorrhagic stroke. So the most common type of stroke is your ischemic stroke rather than your hemorrhagic stroke. Even hemorrhagic strokes are common, but ischemic stroke is more common. Even in the ischemic stroke, we have the thrombotic and the embolic. Okay, so I'm not going into talk about the much details about the hemorrhagic stroke. I'm going to only concentrate on ischemic stroke, how we manage and how we treat them. Okay, so the risk factors. So we divide the risk factors into modifiable and fixed factors. So the modifiable in such, I mean about the hypertension, diabetes, heart disease, hyperlipidemia, smoking, excess alcohol, OC pills, and obesity and sedentary lifestyle. The fixed factors which talks about the age, male people, race, heredity, and hypercoagulability are all your risk factors. Then it comes about your what is the pathophysiology in the management of your ischemic stroke. So the pathophysiology means about what we are going to do in the first few hours of stroke. Okay, so which means we are not aiming to treat the affected area. Okay, so there is a clot which is blocking the arteries, and my aim is not to treat the area which is being occluded. My aim is to treat the penumbra, which means the area surrounding the clotted area. Okay, so which has got, if you don't treat the penumbra, it will go into a permanent damage. So my aim in stroke management would be treating the penumbra and not the affected area. Okay, so that penumbra would be, it is salvageable. Okay, but the clot affected area is not, as we all know, neurons have a irreversible, they cannot be, the damage of the neurons are irreversible. See, they could not be come to a normal functioning. So the penumbra can be damaged by hypoperfusion, hyperglycemia, fever, and seizures. So we need to prevent the patient from having a hypoperfusion, having a high blood sugar levels, and fever and seizures. Okay, so the cause of ischemic stroke would be the differentials. If I see, I will divide this into heart, vessels, and the blood. So in the heart, I will deal about the arrhythmias and valvular problems. So arrhythmias, any atrial fibrillation, the clot dislodges and they can produce a ischemic stroke. That is also possible. Then valvular problems, which include your mitral stenosis and your prosthetic valves. So apart from that, other heart-related issues like your endocarditis, dilated cardiomyopathy, structural heart diseases, and your myxoma, thrombus, and a recent MI can also produce an ischemic stroke. So other causes could be your vessels, so atherosclerotic and your non-atherosclerotic. So which would be a atherosclerotic, meaning your bifurcation of your carotid artery, which is the most common, and non-atherosclerotic, which includes your arterial dissection, vasculitis, and your other moya diseases and all. So in the blood-related problem, you will have your DIC, antiphospholipid syndrome, heparin-induced thrombocytopenia, factor V Leiden. So whenever this blood-related problems are most commonly seen in patients who are having a young stroke. Okay, that's why when we get a patient with a young stroke, we would be sending samples for factor V deficiency, protein C and S thing we would be seeing, homocysteine levels we would be seeing, we would see antiphospholipid levels we would be seeing, antithrombin deficiency we would be seeing in case of a young stroke. Okay, so symptoms. So most commonly, the symptoms we can remember in a very easy way, be fast, which meaning B stands for balancing. So very easily we can spot a patient with a stroke. Whenever a patient is having an imbalance, they're having a headache or a giddiness, and they have a kind of giddiness. This is all a first symptom of a stroke. This is most commonly seen in your elderly. Okay, then they would tell about some problem related to your vision related problems. They could have a diplopia. They could be having a hemianopia. So these are all comes in the eye related problems. So B fast is a very small mnemonic you could easily remember. So F stands for facial drooping. So one side of the face would be drooping. So there won't be there would be absence of wrinkles. There would be absence of facial expressions. This all will be there. Then your arms, there would be weakness of the arms and the weakness of the legs would be seen. Then speech difficulty. Most of the people will have a speech difficulty. And when you see all this, it's a time to call immediately. Okay, so let me deal stroke from the basic to the higher level. So when somebody even the pre-hospital stroke scales, somebody for educating somebody even in the home. We or educating the paramedic. We use pre-hospital stroke scales like your Cincinnati stroke scale, Los Angeles stroke scale, and your Melbourne ambulance stroke scales. Okay, so these 3 stroke scales are available. Okay, so this is just a briefing about what a Cincinnati stroke scale and a Los Angeles stroke scale have things to do with. So most of them have like your facial droop, arm lift, and your speech. This is with most commonly we follow from the emergency department. We teach our paramedics to follow the Cincinnati pre-hospital stroke scale. Okay, so this is an overall view of how each territory can cause symptoms. Okay, so the most common territory which is to be affected is your MCA. Okay, so then is your ACA and your PCA. Okay, there could be some basilar artery occlusion, vertebral artery occlusion. So these all can you have your major stroke syndromes. Okay, so these are the territory in which the ACA, MCA, and PCAs are involving. Okay. Okay, so how do we differentiate from an anterior circulation stroke and a posterior circulation stroke? So most common symptoms like your vertigo, unsteadiness, these are all seen in your posterior circulation stroke. Okay, so they can have symptoms like most commonly they can have symptoms like your giddiness. Okay, so the unsteadiness, these are all very commonly seen in your posterior circulation stroke, and most commonly is your cerebellar signs. So there would be absent finger nose test, the dysdiadokinesia, the pass pointing, it's all will be positive in your posterior circulation stroke. Okay. Okay, so I want all of you to answer. I have a 50-year-old female who is known diabetic hypertension and a CAD for 10 years and on regular medications, presented to the ER with unresponsiveness. She did not wake up since morning. She was last seen normal yesterday night at 10 p.m. What would be my differentials? So I do want the class to be little lively and I want somebody to answer. So what would be my differentials? Yes? Anybody there? Anybody there listening? So you can talk. So I have, you can talk. There was a wake-up stroke answer from Dr. Nirali, stroke, hypoglycemia, acute encephalopathy. So the first thing which Dr. Rajaram has told about is hypoglycemia. Okay, so not everybody who is unresponsive on waking up is a stroke. Okay, so first, before we come into a conclusion that we are dealing on with a stroke, we need to think about other differentials also. Okay, this could even be a simple hypoglycemia. Okay, so we need to check the blood sugar levels. I want you people to talk to me. Okay, so this could be a simple hypoglycemia. So not all unresponsiveness are stroke. So, okay, this is what I want to talk, that not all unresponsiveness are stroke. Okay, so when a patient comes in with sudden unresponsiveness, you should not first think about intubating the patient. We should also look into other metabolic parameters which is causing him unresponsive. So first thing we have to check is your CBG. So if he could be having a simple hypoglycemia which is making him unresponsive. Okay. The next most important thing we have to remember while dealing with a stroke patient is your stroke mimics. Okay, so in the stroke mimics, I have an easy way to remember things. So which is your MINT, metabolic, infectious, neurologic, and your toxins. So in the metabolic, we have things like your hyperglycemia, hypoglycemia, Wernicke's encephalopathy, MELAS, which is your mitochondrial encephalopathy, hypertensive encephalopathy, hypoxia, and hypercarbia. Okay, so in the infectious, we have the Bell's palsy, vestibular neuronitis, CNS abscess. And in the neurologic, we have the seizures, brain tumors, traumatic brain injury can also be there, and sometimes your conversion disorders. toxins, which are the next most important things which could mimic you a stroke. Okay. So this is a small, simple door to needle time, which every emergency department practices throughout the world. Okay, so when a suspected stroke victim comes to the ED, within 10 minutes, the emergency physician does the initial evaluation, rules out all the stroke mimics. Okay, for us to take and to rule out in hyponatremia, it takes only a few minutes. Okay, so we do an ABG to check for hyponatremia if it is there, and to check the CBG, it takes very few seconds. Okay, then we knew that it is a stroke. We do the NIHS stroke scaling. Okay, so by then we alert the stroke team, and then we get the we alert the radiological department for a CT or an MRI. And within 45 minutes, the image has to be interpreted, and within 1 hour of patient's arrival, the altiplase or any other thrombolytic agents should be initiated. Okay. So next, preparing a NIHS stroke scale. This preparation of NIHS stroke scale is very, very important. So any patient who is presenting within the window period, so any patient who is presenting to you within 4.5 hours of acute stroke, we would be doing the NIHS stroke scale. This is a 11 component stroke scaling, which includes different components. Okay, so you would be seeing the level of consciousness first will be there. In that, you can grade it into 0, 1, 2, and 3. And then we'll have your gaze, which the 2 tells about the gaze, and 3 tells about the visual, and 4 talks about the facial palsy, and 5 talks about the motor arm, and 6 talks about the motor leg, and 7 talks about the limb ataxia, 8 talks about the sensory, and 9 talks about the language. 10 talks about dysarthria, and 11 talks about extension and inattention. Okay, these are the things which are components of the NIHS stroke scale. So this can be graded from 0 to 42. Okay, so whenever we are encountering a patient with a stroke, then we follow this NIHS stroke scale. So how with the stroke scale? See, you need not memorize everything about the NIHS stroke scale. Everybody has a calculator where you just type into the numbers, and then it gives you the stroke scale value. So even in some of the EDs have it in their case sheets. Okay, so we then any stroke scale which is coming between 5 to 20 is an indication for thrombolysis. And the most important thing, the patient should be presenting within 4.5 hours. Okay, 0 means there is no stroke symptoms. 1 to 4, the patient has got a minor stroke symptoms, and 5 to 15, there is a moderate stroke symptoms, and 16 to 20, it's a moderate to severe stroke, and 21 to 42 is a severe stroke. Okay, so 5 to 20 only we decide to thrombolyze. Either which is less than 5, we don't thrombolyze, or which is more than 20 also, we don't thrombolyze. Some institutions, they even don't go up to 20, they restrict to 18 also. Okay, so whichever is your institution protocol, you can follow, but we can, from 5 to 20 is the thing which we decide for a thrombolysis. Okay, so then we are coming up to the ABCD score, which is for the TIA. So can we thrombolyze a patient with TIA? Can I have the response? Can we thrombolyze a patient with TIA? Can we thrombolyze? No, not required for TIA. I think you can all speak. Okay, then it will be easier for me instead of me looking into the chat. Okay, so not required for your TIA, because it is, how do you know? Only after 24 hours, if it is reversible, only know you will know whether it is TIA or not. Then how do you decide not to thrombolyze somebody? Yes, anybody? I think it is better to talk rather than to type. So only if it is persisting for 24 hours, only you will know whether it is a TIA or not. So how do you decide whether it is a TIA or stroke? Yes, please. muted. Okay, you're on, we are muted. Okay, I can understand. Okay, so I will tell you in my next future classes. So this ABCD scoring is for the TIA. So in this, there are these. It's for two duration of the symptoms and diabetes. Okay, so in the duration, if it is more than 60 minutes, the scoring is 2, and if it is a by unilateral weakness, the scoring is 2. Okay, so for any patient who's got a scoring more than 4 points are at increased risk. Okay, case scenario 2. So we have a 65-year-old male who presented to the ER with right-sided weakness for 1 day. Started from waking up in the previous day morning, and it gradually progressed and worsened today with aphasia, pooling of secretions, and increased respiratory rate. Okay, his heart rate is around 116, his BP is around 190 bar 80, and saturation 86 in room air, and respiratory rate is 35 per minute. Okay, so my question now is not what is his differentials. My question now is, we know he has got a stroke, some form of stroke. Okay, it could be either an ischemic or it could be either a hemorrhagic stroke. So he has some kind of a stroke, and all we assume that all the ABG is absolutely normal. Okay, so now what investigation do I put my patient for? Okay, so I want whether it is CT or MRI for this patient with the above history. Okay, so I got different answers. MRI brain with DWI, flare DWI, and CT brain is some answers are there. So what would I prefer for this patient? Okay, non-contrast CT brain is the first. Exactly, non-contrast CT brain is the first. So MRI, for we know that patient has got a heart rate of around 116, who's got a respiratory rate which is about 35, and I know the patient, if I put him flat for an MRI, definitely he's going to aspirate and he's going to still become worse. So I prefer a non-contrast CT brain or a CT with an angiography. Okay, which solves all my problem. Okay, so either a plain CT or CT with an angiography, cerebral angio. Okay, so why CT, not MRI in stroke? See, CT is not inferior. CT is the most important thing for a stroke. It can even pick up strokes very, very early also. So we do any kind of patient who is unresponsive, instead of wasting our time in the MRI, we can do CT initially to rule out a bleed, to demonstrate an hyperdense vessel. So which is a very evident. Okay, which we called as a MCA sign. Okay, so then if it is stroke is already evolved, it shows you features like this, and you could see all this little bit of hyperdense areas, which can tell you that it has got an hemorrhagic transformation. And then if the patient has got any other alternative etiology for the symptoms, so you feel that he's got a round demarcation following an edema, so it could be some kind of brain tumor. Okay, so the earliest sign of ischemic stroke in a CT could be a hyperdense MCA sign or a MCA dot sign, and a loss of gray-white differentiation and hemispherical sulcal effacement and attenuation of lentiform nucleus, which I will be showing you. Okay, so this arrow shows you a hyperdense MCA sign. So by looking into this, it doesn't mean it is a bleed. Okay, so any acute stroke will show you a picture of hyperdense MCA. Okay, this is a sign in a very early stroke. Okay, so this indicates right MCA artery thrombus. And then we have the loss of gray-white differentiation. You could see from here and here. Okay, so then you could see how this side large area of hypoattenuation with sulcal effacement with mass effect in the right MCA territory. So here and here you could differentiate. Okay, so you could see how sulcal effacements are there. See the sulcal effacement. Okay, so early ischemic stroke signs, which is your hyperdense artery and loss of insular ribbon sign and lentiform blurring and loss of gray-white differentiation and sulcal effacement. Okay, so some next question we'll go. What if the patient comes to me at 4 hours after stroke? What imaging should I do? Okay, the patient is exactly presenting to me at 4 hours of stroke. So I just have half an hour left. What do I do now? Okay, so somebody said CT perfusion study, CT brain. So we will now get ourselves little refined. Instead of doing, we have only half an hour left for treating this patient. So we have to go for CT cerebral angio. So we will change our ideas from a plain non-contrast CT to a CT brain with a cerebral angiography. Okay, so that would be the better. If your institution supports for a CT with cerebral angio, it's a best investigation. So you can look into the vessels and you can even thrombolize immediately. Okay, so why if the CT brain is normal, definitely I'm going to thrombolize. Why do I need an angio to determine whether to thrombolize or not? Please, you can text. Do the chat. Why do I require a CT angio? Just a plain CT is going to tell me whether the patient has a bleed or not. With that, yes, exactly. It is for the intervention. Okay. So whether I should, as I already told you, time is brain. I should not waste time. So how early I look into the vessels, I can even plan for an intervention. If my thrombolysis is not working out, I'm going to plan for an interventional radiologist. I'm going to make things ready for the interventional radiologist. Okay, so that's why I need the angiography. Okay, so the dictum would be now it is not from a non-contrast CT to a CT cerebral angio with stroke symptoms for all patients with stroke symptoms who are nearing or nearing who coming into the who are falling into the stroke picture. Okay, so what do we do in the ER? So primarily our aim, anything in the ER would be ABC, airway, breathing, and circulation. So first thing I'm worried about is maintaining the patient's airway. So if he's having a gurgling sound, if he's not able to maintain the airway, I secure the airway. Then I look into his breathing patterns. So if there is any aspiration, signs of aspiration along with the CT, if he's crossed the window period, I will go for CT chest and start him on early antibiotics and circulation. If the BP is maintaining, I do all this ABC management and get an IV access, look into all the vital parameters and other things. As I told you, the ABG, which is very, very important for this patient to look into the glucose level, to look into the sodium level, potassium level, and a non-contrast CT first initially, which is presenting early, and preferably CT with a cerebral angio. Okay, so other things like, as I already told you all this. Okay, so now treating the patient. So this should be most importantly noted. So what blood pressures we are going to maintain for a patient with a stroke? Okay, so we decide a patient to give a thrombolytics. So we need to maintain a BP less than 180. Okay, so if we are not deciding to thrombolize the patient, we can maintain a BP up to even 220. Okay, not more than that. If the patient has got an intracerebral hemorrhage, we can lower the BP up to 160 and SAH 140. Okay, so why are we maintaining this BP? Why are we looking into BP of 220? I know it is higher BP, but why we are not reducing the BP in the first 24 to 48 hours? Why are we not? Yes? Yes, to save the penumbra. Okay, our aim is not to treat the stroke affected area. Our aim is to treat the penumbra. So that's why we are maintaining a higher BP for all these patients. Okay. Okay, so what do I use for maintaining the BP? So I preferably use a beta blocker, a labetalol, or a nicardipine infusion, or a clevidipine I can use. Okay, so my aim is to check the BP every 15 minutes. Okay, so if the alteplase therapy is given every 15 minutes, I used to check the BP, and for the next 2 hours, and every half an hour for the next 6 hours, and every hour for the next 16 hours. Okay, so this is how I should maintain the BP. This is how I should maintain a chart. Okay, so now another question. Patient presented to me within 1 hour of stroke. Can I thrombolyze the patient after 3 hours? The patient is presenting immediately to me. Okay, so still I have 3.5 hours left with me. So my postgraduate says, so I can, ma'am, I have still time. So I will go for CT, cerebral angio. Then I will do an MRI, and then I will come again. And then even then, it's not going to take me more than 1.5 hours. Can I do that? Yes, can we do that? So patient is coming to me within 1 hour. So can I wait for another 3 hours to thrombolyze, or another 1.5 hours to thrombolyze? No. Yes. Yes, somebody. The answer would be, how early you treat the stroke, the more beneficial it is. So you cannot wait for another 3.5 hours to complete the entire 4.5 hours. You should not wait. Even the patient is presented to you within 5 minutes. Your running speed should be, you have to complete giving the alteplase within 1 hour. So whatever it is, time is brain. Exactly, Dr. Rajaram. Okay, so however early they present to you. Okay, should I delay thrombolysis for lab values? This is my next question to you. Okay, so any indication or contraindication for the thrombolysis says you need to look into a platelet value. So should I wait for the platelet value? Should I wait for the INR value in case of acute stroke? No is some answer. Yes, exactly. So don't wait for any of the lab reports. My aim is to thrombolyze the patient, give the thrombolysis, whatever it is. Do not delay thrombolysis. Exactly. There is no active bleeding, you can go for thrombolysis. Okay, so low NIHS, should I consider thrombolysis? So as I've already told you before, any NIHS scoring less than 5 or more than 20, we don't do a thrombolysis because they are not going to have any major deficit with a low NIHS stroke scale. So we need not give a thrombolysis for a low NIHS stroke scale. Okay, so now recent evidences we will look into. A seizure and a stroke. This is a very, very controversial topic. So somebody presenting to you with a stroke and a seizure. Okay, do you decide to thrombolyze them? So we would have faced all these questions while seeing the patients. So can we thrombolyze a patient with seizure? We have to do. If no bleed. Okay, stroke and seizure and stroke. Can we thrombolyze a patient with seizure who is presenting with acute stroke? See, seizure itself tells that the patient will have a cortical involvement. Okay, so if the patient is having 1 or 2 episodes of seizure, then yes, you can go ahead with thrombolysis. But if the patient is having a status epilepticus, which means the large area is involved, then you have to think whether the NIHS stroke scale will go above 20. So for those patients who's having a status epilepticus, your stroke scale itself comes above 20, so you cannot thrombolyze. But a patient who is having 1 or 2 episodes of stroke, who is having a seizure at the onset of stroke, but coming to the ED, no seizures, patient is having a stroke scale within 20, you can go ahead with thrombolysis. Okay, the next question would be LP and a stroke. Okay, the patient had a recent history of meningitis. Okay, you have done an LP a week before. Okay, can we thrombolyze this patient? No answers. Yes, so within 1 week, yes, you can go ahead with thrombolysis. Okay, so what if my patient has acute stroke with ECG changes? Okay, what dose of thrombolytic agents should I use? Okay, so my patient has got an acute stroke along with some ECG changes. So should I thrombolyze for the heart or should I give thrombolytic agents for the brain? Is my next question. So this also you would be definitely facing. Okay. So these are all the questions which my PGs used to ask me. Okay. So a patient with an acute stroke will definitely have an ECG changes, will have an ST elevations. Okay. Should now I use alteplase at the MI dose or alteplase at the brain dose? No answers. Alteplase at what dose? At a usual dose for brain, yes. So the ECG changes in any acute neurological event, there would be ECG changes. Okay, so it doesn't mean I'm not telling you to leave the heart, treat for the brain first. Okay, even after treating the brain, the patient is having a persistent ECG changes, his neurological part is stabilized, then we can shift him for a PTCA. Okay, in later, but not give for the hard dose. You should always give for the brain dose. Okay. Okay, so the dose for alteplase is 0.9 mg per kg. Okay, so in this, the 10% of the dose is given as an initial bolus. Okay, and the remaining 90% is given as an infusion over 1 hour. Okay, 0.9 mg per kg is the dose for ischemic stroke. Okay, so this is how you need to give alteplase. Okay, so after alteplase, okay, shift the patient to the either if your ED has a facility to observe the patient in the ED for 1 hour, yes, or you can shift the patient to the ICU. So if the patient develops headache, hypertension, nausea, vomiting, immediately stop the infusion and send them for an immediate CT scan. Okay, so while the alteplase is going on, every 15 minutes, BP has to be assessed and BP control has to be done. So before putting the patient on an alteplase, so you can put the Ryle's tube, Foley's catheter, whatever lines you wanted to secure the lines. But for a patient who is absolutely fine, who has got mentation, good GCS. So if you want, ma'am, should I put a GCS is fine. Should I put a NG tube and Foley's catheter? Not necessary. It depends patients to patients. The patient who's got a low GCS, yes, you can put a Ryle's tube, Foley's catheter and all. But patient who's got a good GCS, it is not necessary that every patient you have to put them on a Ryle's tube and a Foley's catheter. Depends upon the necessity of the patient. Okay, so it is mandatory to get a CT scan, CT brain of 24 hours after the alteplase, and the anticoagulants should be started after 24 hours. So while giving the alteplase, before itself, you should not give aspirin. Okay, this is what the mistake we all do. So patient coming with acute stroke, we immediately put aspirin. No, if the patient is coming within the window period, when we decide we have decision to thrombolize, you need to wait, hold on with the aspirin dose. Only after alteplase 24 hours only you need to give your ecospirin dose. Okay, so you knew that the dose of alteplase is 0.9 mg per kg. Okay, so maximum up to 90 mg you can go. Okay, so contraindications for thrombolysis. Okay, this would be there. So the inclusion criteria. So most commonly we go with less than 3 hours. I will tell you why 3 hours. The extended period now is 4.5 hours. Now even the extended stroke treatment goes even up to 24 hours. Okay, so measurable diagnosis of acute ischemic stroke by using the NIHS stroke scale. And anybody who is above 18 and the onset is 3 to 4.5 hours prior to a RTPA administration. Okay, so exclusion criteria. Okay, last well-known time is more than 3 hours to 4.5 hours. It is not an absolute exclusion criteria. Any you can put this will not come under an absolute exclusion criteria. Okay, so then intracerebral hemorrhage, yes, and history suggestive of SAH, no, you should not go for thrombolysis. So they are telling last well-known time more than 3 to 4.5 hours. Now this is also coming into the inclusion criteria. Okay, previously they were not telling more than 3 hours you should not thrombolyze. Now they have extended the time from 3 to 4.5 hours. So we can even consider thrombolysis for above 3 hours to within 4.5 hours. Okay, so then CT imaging suggestive of hypoattenuation, clear hypoattenuation. So prior stroke, And previous ischemic stroke, they're telling again not to thrombolize, not like that. You can even go ahead with thrombolysis if they are fitting into the criteria. Okay, so any spinal surgery within 3 months, and then any GI malignancy or GI bleeding within 21 days. Okay, so then this is another table which is telling if the platelet count is less than 1 lakh. So you need not wait for the lab values at all. The INR more than 1.9. These are all given in the books, but ideally we are not going to wait for any of these values. Okay, so most important. Okay, we have decided somebody to thrombolize. Next, it's a consent. In this, I'm going to talk about the what is the relevance of each and the consent in thrombolysis. Okay, how do you get a consent for a thrombolysis? So we know the cost of the drug. It is definitely 45 to 50,000. Okay, so whenever we are giving a very costlier medication, even for 100 rupees, 200 rupees, our patients used to ask 1,001 questions. But when we are giving a medicine which is costing around 50,000 and which is having a lot of complications, how do we counsel them? That is also very, very important. Okay, so the most important is to get a proper consent. Okay, so we need to talk to them. So this is what I wanted to put into. So when the patient is presenting to you within a 3-hour window, okay, you should tell them of all the patients who are receiving the thrombolytic agents, 30 out of 100 patients only will have a better outcome. Okay. Okay, patients can also 3 out of 100 patients will definitely have the complications of TPA. Okay, so if the window is extended, that is 3 to 4.5 hours, only 7 out of 100 patients will benefit. Okay, which means and the complication is also at a higher rate. Okay, this is how you need to tell the patient. Okay, so as early they present, the 30% can have a better outcome and 3% can have a complication. But if they present in the 3 to 4.5 hours window, the complication rate is very, very higher. Have a symptomatic bleed. Okay, so complications of thrombolysis. So whenever we know the complication of thrombolysis is the bleeding. So whenever you have bleeding, stop when the patient is having a headache, sudden vomiting, stop the alteplase infusion and get all the, before itself, you need to send for all this. So CBC, PT, INR, APTT, fibrinogen level, get a cross-matching, everything get ready. Okay, so the treatment is to transfuse a cryoprecipitate, tranexamic acid, and control of blood pressure management. Okay, so next complication is your orolingual angioedema. Okay, this is also a complication of this alteplase. So this is like your anaphylactic reaction, anaphylactic shock. So treat accordingly. Okay, so management of TAA, you should start on with the anticoagulant aspirin immediately. Okay, so we even have surgical treatment for it. So the stroke management, apart from your thrombolytic agent, then is coming your antiplatelet therapy, should be started only after 4.5 hours or after 24 hours in case of a thrombolytic agents being given. So how do we see? There are a lot of neurologists who are giving dual antiplatelets. Some are giving single antiplatelets. Okay, so whom do you decide to give a dual antiplatelets and whom do you decide to give a single antiplatelets? Okay, so this is also you could see very commonly. So some neurologists will prefer giving a aspirin alone. Some neurologists will give both clopidogrel and aspirin. So how do we decide on this? So it depends upon different on the neurologist. So in my institution, what my neurologist follows is, in case of a massive stroke, he gives only a single antiplatelet. Okay, in case if it is a moderate to mild stroke, he gives on with a dual antiplatelets. This is how he decides. In most of the places also, it is given in that way. Okay, so newer oral anticoagulants, like for a long-term patients, you can put them on dabigatran, apixaban, and rivaroxaban. Okay, so next, the treatment. So now the stroke window is not only 4.5 hours, it's extended to 24 hours, which is your mechanical thrombectomy. Okay, so who are presenting within 24 hours, we can go for a mechanical thrombectomy. Okay, so we have two different trials, which are your Dawn trial and your Diffuse trial. Okay, so you can go through about all these two trials. So you can take a screenshot and go through about all these trials. Okay, so who are presenting within more than 6 hours to 6 to 24 hours, we can use a Dawn and Diffuse trial, and we can assess them and we can subject them for a mechanical thrombectomy. So can we do mechanical thrombectomy for a PCA stroke? Can we call the interventional radiologist? No. So even you do interventional radiology, by interventional people you call for a posterior circulation stroke, it doesn't got any better. They don't even touch a posterior circulation stroke. Okay, so or basilar artery occlusion, they don't even touch a basilar artery occlusion. So how do I treat a wake-up stroke? Okay, so I don't know. So anybody can answer, how do I treat a wake-up stroke? Somebody presenting to me, the last seen normal is around night 10 o'clock. The next day morning, they're presenting to the ED at around 8 o'clock in the morning. So do I decide, how do I thrombolize this patient? When I thrombolize this patient, I don't know when the stroke had occurred. The stroke had occurred, would have occurred at 7 o'clock in the morning. The stroke would have occurred at night 11 o'clock. So how do I decide to thrombolize them? Can I thrombolize them first? No messages. Diffusion weighted MRI. Exactly. So we need to go for a diffusion weighted MRI. So how is diffusion weighted MRI? So this talks about the aspect score. We'll talk about the aspect score next. So this is your wake-up scoring. So this is not only diffusion weighted MRI. This is called as a diffusion flare mismatch. Okay, this is the right word, Dr. Anil Chaudhary. Okay, so you see a picture which is A, B, and C and D. Okay, so this is your in the MRI sequence, we have two things called as your diffusion weighted imaging and your flare imaging. Okay, so this A, let's make cursor. So if you see in the diffusion weighted imaging, I could see one hyper intense area, but in the flare, I couldn't see. So there is a mismatch. So this tells me that the patient is falling within an acute stroke window. So I can thrombolize this patient. But if you see this picture, so in the diffusion weighted also, it is like this. In the flare also, it is like that. So this means I cannot thrombolize this patient, which means a stroke has occurred after 4.5 hours. That is with after my window period. So I cannot thrombolize this patient who is fitting into the criteria of C and D. I can thrombolize a patient with A and B criteria. Okay. This is what a diffusion and flare mismatch. Okay. So now I will talk about the aspect score also. So something to do with your aspect score. Okay, this is also a part of your stroke algorithms. It also comes. So this has got a 10-point quantitative topographic score for a stroke patient, MCA stroke. This is only involving the MCA stroke. So this doesn't has got much impact. So each area is given 1 point. You see. So M1, M2, M3 has one point. This is in the basal ganglia level, and this in the corona radiata level. M4, M5, M6. And this area is your caudate, your internal capsule, your lentiform nucleus, and your insular cortex. Each 1 point. So totally there are 10 points in case of an aspect score. So which those areas have been affected, it's given 1 point. So the higher the scoring, the more the probability the patient is sicker. Okay. So this is talking about your aspect score. So this I talked about your wake-up stroke. So next new thing in your stroke is your arterial spin labeling. This is newer. Okay, this you wouldn't have heard about. This is another, in the MRI sequence, you have another thing called as your arterial spin labeling. So this will tell you about the perfusion diffusion mismatches. Okay, so this imaging can be done within as fast as 2.5 minutes, but this has to be read by a radiologist. If your hospital has got all the facilities, a radiologist available 24 hours, you can even subject the patient immediately to arterial spin labeling in the MRI sequences. Okay, this will tell you a stroke. It can pick up within half an hour. A stroke can be picked up. So this is a newer in stroke. Okay, so this is in the higher hospitals are following this protocol. Okay, so newer drugs in stroke management. So we before the FDA had not approved tenecteplase, but since for the cost factor we had been giving tenecteplase before, but now FDA has approved tenecteplase. So some people tell we can even give magnesium sulfate, which has got a neuroprotective mechanism, and some tell we can give melatonin, but we don't give initially in the stroke. It is not all treatment for acute stroke management, but in 2 to 3 days we can give melatonin. So next drug, which is your sovateltide. So it is your highly selective endothelin B receptor agonist. So this can be given for patients who are presenting within 24 hours. It is not, these are tenecteplase only is for thrombolytic agents. The other drugs are for your maintenance dose, just to prevent. Sovateltide is also very, very effective drug, which has recently been given. This is given at a 3 days interval dose, on the first day of the stroke and third day and the 6th day it is given. 3 doses are being given each day. Okay, so this has got a promising result even for a posterior circulation stroke. So that has also been given in most of the hospitals recently. So the targets, not only in our hospital, in most of the hospitals, the target should be door to doctor within 10 minutes. The door to treatment should be within 1 hour. You need to administer your alteplase. Okay, so shifting them to an ICU should be within 3 hours. Okay, so this ends my stroke. Things about my ischemic stroke. So if you have any doubts, you can put it here. I would be happy. Yes, sovateltide should be given as an infusion. Okay, this is given as a half an hour infusion in 500 ml MS. Citicoline, see, they're all having a neuroprotective effect. Yes, citicoline is given, neutrophil. They are all given in a stroke management. Ischemic stroke with hemorrhagic transformation. Yes. So if you tell the hemorrhagic transformation, role of low molecular weight heparin in ischemic stroke. So let me read one by one question. Okay. So hemorrhagic transformation, first I will answer. So when we have a patient who's got a stroke, we would definitely start them on we go for a thrombolytic agents, and then who's got a hemorrhage, then we will treat the hemorrhage by cryoprecipitate and all. But if patient who's crossed the window period and is presenting to you with hemorrhagic transformation, we limit our role from dual antiplatelets to a single antiplatelet at a lower dose. Okay, so there is no role for low molecular weight heparin in ischemic stroke. Okay, it only has a DVT prophylaxis, but it doesn't have any role in stroke management. Okay, cerebroprotein role. So these are all drugs which are given, but they don't have effective role, which means that they reverse. It is not there. It is like your neutrophil, parapinel, like that. Okay, so that is not. They are not effective treatment. First have to do non-contrast CT, rule out bleed, and then thrombolyze. Okay, so it depends upon your institution. If your institution has got uh, uh, people who can read your CT cerebral angio, yes, and your institution has got interventional radiologist, yes, you can go ahead with CT with cerebral angio. They have to manage systems verified and role. Then how about MRI room, diffusion weighted. See, so now they are talking about things are getting advanced day by day. So it depends upon how your institution is equipped. If your institution has got better radiologists to report your spin labeling and all, you can go for better technologies rather than your old ones. Okay, so it depends upon your institution, where do you work and how facilitated it is. It is if you have a no, sir, first do a non-contrast CT, see if there is no bleed. If there is no bleed, immediately get the thrombolytic agent even to your CT console and proceed on with your cerebral angio. Look for the vessels. Look for the vessels, and then proceed on with your thrombolysis. Okay. So, next questions. Okay. Welcome husband even in hemorrhagic transformation. So I will go with, if the depends upon how big the hemorrhagic transformation it is. If it is very big, I will go only for platelet. I don't go for aspirin. No, ischemic stroke with aphasia, any drug, no. Antiplatelets only. Patients or MI patients on acetylene or aspirin. So after 10 days, you can restart your acetylene and aspirin in case of hemorrhagic stroke. We will shift. No, I've already answered. If it is a huge hemorrhagic transformation, I would I will not give any of my antiplatelet agents. But if it is a small hemorrhagic transformation, I will go with a single antiplatelet. Could be either aspirin or a clopidogrel. The patient for craniotomy in PCS stroke with GCS 3 to 5. See, it doesn't mean every PCA stroke requires a craniotomy. It depends upon how the patient is presenting it, raised ICP. If it is a huge stroke, PCA stroke, and it is the patient is completely not responsive, not having any compressing the brainstem reflexes on it, there is no point in doing a craniotomy. It depends upon what are the cranial nerves which are functioning for the patient. Then we decide to do a craniotomy. Valvular heart disease patient or anyone. Okay, this I have answered. So the mannitol is TDS dose on day 1, and it says more than 3 days the role of mannitol is not there. So we cannot generally abruptly stop the mannitol. Gradually taper from TDS to BD and then OD, and then I will stop. So the hypoattenuated area, not only the looking up to the hypoattenuated area, also a NIHS stroke scale. As I already told you, NIHS stroke scale plays a very important role in this kind of situations. So look into the NIHS stroke scale, look into the MRI findings, and then decide to thrombolyze a patient. So after thrombolysis, only after 24 hours, we decide to start on the antiplatelet therapy. So we can go up in the initial days, I can go up to 15 ml per hour. So it is 2 bottles of 20% TID or 1 bottle TID. It depends upon what are the heart rate and BP of the patient. Okay, if he has got signs of raised hypertension, I prefer to push him for a decompressive craniotomy rather than loading him with the mannitol. I prefer going with a 1 bottle TID. Okay, so the role of anti-epileptic drugs. See, there is no role for prophylactic anti-epileptic drugs at all. So when the patient is having seizure and we continue to give them anti-epileptic. Okay, so as a neuroprotective also to some in most of the institutions they are continuing it. Definitely, anti-epileptic should be given. One episode of seizure, yes, they have to continue the anti-epileptics until 5 years, and then based on the consultation of neurologists, they can stop the anti-epileptics. Any other doubts? What are the indications to intubate a stroke patient? See, not indications for intubation is general, not only for a stroke patient. You feel the airway is threatened, you intubate. Okay, so the indications for intubation doesn't for a different etiology, it doesn't differ. So whenever you feel there is a threat for the airway, intubate the patient. Okay, maintenance is with the dual antiplatelets. I hope most of the questions I have answered. Anything else? Physiotherapy. Okay, so physiotherapy on which day? So I suppose I have thrombolized a patient within 24 hours. Not the next day I'm going to do a physiotherapy. Okay, so it is better to start all your physiotherapy after 48 hours. So preventing stiffness is our aim. So we need to initiate early physiotherapy, rehabilitation. Thank you. I hope I have cleared most of your doubts in managing an acute stroke. So this is all we face day in and day out. These are the unanswered questions by most of the people. Thank you so much.
Thank you, ma'am.
Yeah.